this. All right, well, firstly, thank you so much for coming to my session. I know there are so many great presentations. I think there's 4 of us speaking concurrently right now. So thank you for coming. That's like a tremendous honor. So my name is Katherine Benjamin. I have about 10 years of experience working in healthcare, primarily on a variety of patient-centered health programs. I've worked in Canada, the UK, and Southern Africa, and then I recently moved into digital technology, and I worked on a pretty high-profile transformation project in NHS in England. So my presentation today is called Give Them What They Want, Using Patient-Centered Innovation to Rock the Boat and Change the System. So I like to start my presentations with this quote: "It always seems impossible until it's done." This quote, of course, is widely attributed to Nelson Mandela, and it was presumably said in the context of his work against the apartheid government in South Africa. The reason I like starting with this quote is because when I saw it on the wall of the gym, it struck me as really odd. Because in this place, they were using the language of activism in this context against a horribly oppressive system of racial segregation, and using that language to push a customer to go an extra mile on a Stairmaster. And that struck me as really misplaced. But the language of activism is highly marketable. Increasingly, we see words like patient-centered and co-production and patient-led being thrown around. And this is part of the broader movement for patients to be more involved in their care, of course. But one of the reasons that it's being used so much recently is because there's pressures on health systems. So what's happened is that people misinterpret the language of activism as an excuse to get patients to do our job as health system providers for us. Particularly here in the United States, this language often calls upon the notion of the American dream. It's calling for patients to pull themselves up by the bootstraps, but it's not challenging the broader socioeconomic determinants that have led them to be disempowered in the first place. So in this case, what we have is a really challenging set of circumstances. And we have a situation where this language of empowerment has been hijacked by people who aren't really empowering people. And that becomes really difficult. And it undermines the real people who are working on the ground to transform health systems. So I'm going to talk about 3 things today. I'm going to quickly define what I mean by authentic empowerment and contrast that with tokenistic empowerment. I'm then going to talk about 3 examples I have had in my career trying to use really authentically empowering things in health systems. And then I'm going to get to the really important stuff, which is talking about how do we scale some of the things we see in really innovative grassroots programs, and how do we bring that to the mainstream so it's not the exception, but rather it's the rule. So I'll start by defining tokenistic empowerment. Tokenistic empowerment is about getting other people to change without actually changing ourselves. It's about using the language of the everyone included model without actually doing the tangible things to ensure that people are included. It's about offloading the responsibility for change onto a marginalized group without critical reflexivity, without asking ourselves what our role is as people within a system to be part of changing the structural imbalances that are leading to people being disempowered in the first place. The challenge with empowerment and power generally is that power is a finite resource, though we don't speak of it as such. If one group is going to gain power, then they have to take it from another group. If you think about a tangible example like the women's rights movements, when women gained more control over their bodies and their lives, it's because they vociferously demanded that from the people and the organizations and groups who had been oppressing them. Empowerment and power is really a Pandora's box. So once we empower patients, we can't define what they then do with the power they have. We can't empower people towards our own objectives, and that's one of the challenges we have in health systems when we empower people and then hope that they're still going to play by our rules. So authentic empowerment is different than this. It's when we say, let's help people enhance their capacity to make choices, and then help them to leverage those choices towards the desired actions and outcomes that they see fit for their lives. And the first place I really came to see this in action was when I was a volunteer for a registered Canadian charity called the Beauty Night Society. So Beauty Night provides makeovers and other wellness programs for women living in Vancouver's downtown east side. And this is where I learned how important it was to really listen to service users or patients. So when I was a volunteer for Beauty Night, I created a spin-off project called Women's Gym. And Women's Gym provided free personal training and other fitness services for people who were Beauty Night clients. The idea had been that at the time I was a human kinetics student, and what I was hearing over and over from beauty night participants was that they were desperate to participate in exercise, but they couldn't because they didn't have perhaps running shoes, maybe fitness apparel, or they'd been a victim of domestic violence, and so going into a gym and participating in a male-dominated space was tremendously intimidating. So the idea for us was, what if we paired human kinetics women like me and paired it with people who wanted to learn about fitness, and we'll have a great time. And in that sense, it was a very successful program. But it wasn't until later that I realized that the reason people came to my program is because they felt authentically in control. They were the ones telling us what they wanted, and we were just flying by the seat of our pants, inventing solutions that resonated with their needs at every step of the way. And I wish I could say that it was because I was totally enlightened, but it was actually because I had no idea what I was doing. So I just listened to what people wanted and just kept doing what they wanted, and it kind of worked out. As I moved along in my career, I later went to the London School of Economics, where I wrote my master's thesis and later worked in a service called Open Doors. So Open Doors is a clinical outreach and case management service for people involved in sex work. And this is funded by the UK health system, the NHS. And it was there that I learned what it meant to work for the patient. Because working for the patient is actually quite easy. You just have to work for the patient, it's not hard. It's also not tautology. The trouble that we have in health systems is that we often set up a really cumbersome bureaucratic process and then declare ourselves to be accessible simply because we have the lights on. This is not working for the patient. If you want a program to work, it has to authentically resonate with the needs of the patient, and that's really hard. Because what the patient wants and what the health system wants is often two different things. And this isn't to say that they're wildly different. It's often that the health system has a public health agenda, and that specific objective just might not resonate with each individual that you're speaking to. I worked extensively with these hard-to-reach populations, and here's what I've noticed. Hard to reach is often a term used by people within health systems trying to describe a service user who's not playing by their rules. By this I mean, this is the same type of lazy service provision where a group says that they're going to serve a nocturnal population, like people involved in sex working, but then they'll set up a drop-in from 11 a.m. to 2 p.m. It doesn't make any sense. But I totally get it, because working in the middle of the night is really annoying. It totally throws off your social calendar. It makes your life really difficult. But if you're not doing that, then are you actually working for the patient? At Open Doors, we did things differently. We restructured our approach. We put our organizational needs behind the needs of a service user. And although we still had a public health agenda, and our service users knew that, they also knew that they were in the driver's seat. And what we discovered was that these so-called hard-to-reach populations weren't hard to reach at all. Because if you drive up and down the road at 4 a.m. with hot coffee and a non-judgmental attitude and give a patient-centric offering, you're going to have hundreds of people knocking down your door. And I know this because that's what happened to us. So what I'm talking about here is moving organizational objectives, adapting the way you work from a really paternalistic approach to a collaborative approach. And I'm not going to pretend that's easy, because it makes life inside your organization hard, because that's not how we originally set up our health systems. But this is a more ethical and also a hugely more impactful way of doing business. Now, talking about patient-centric service design at MedX is a little bit ridiculous, because it's totally preaching to the choir. I get that everyone is behind this. The reason that I covered this so far is that it lays the foundation for what we do when we try to scale these programs. How can we find ways to look at what we know works on the ground and bring that to the masses? If you were to ask the National Health Service, which is the world's largest single-payer health service and my former employer, they would say, one way to do this is to harness the power of technology to empower people at scale. If we're thinking about MedX, the X in MedX represents the infinite number of possibilities for technology to improve health outcomes. So maybe one way that we could do this is to use what technology does, enabling us to get things faster, to make things easier, to do it on a scale that previously was just not tenable. What I'm suggesting here is that we use things like industry-level product design methodologies and use that as a way to bring patient-led initiatives into health systems. So I recognize that that's a lot of buzzwords all at once, so allow me to explain this a bit. industry uses contemporary design practices like agile and user-centered design. That's how people make really great products that people want to use. What's nice about this is that users are included in every step of the design process. So in the NHS, when we needed to build a new diabetes service, something digital with diabetes, we started by talking to users and understanding what their issues were. And that's how we created an app like this. It was just a prototype, but it was built in direct response to what users were telling us. And we had a formalized mechanism to do that, which was using these contemporary design practices. So it enables us to design really innovative solutions to complex problems, but it also becomes a little bit difficult because we have to be brave enough to innovate solutions that resonate with the complexity of the people we're working with. Because a lot of these design practices are super helpful, but they're often quite niche, or they're talking about one specific product. And in healthcare, people have tremendous diversity. One thing doesn't work for everyone. So the bravery comes in when you're in a health system and you're having to go back to your organization, the way we did at Open Doors, and say, how do we need to adapt the way we're working so that when we innovate a really good patient-centered solution, we have a way to integrate it meaningfully in our day-to-day work. So if you were someone like IDEO, you would use a methodology like this. And it's not the only methodology, but it's a good one. And at every stage in the process, you're talking to patients. This is really great. But if you're someone like me working in a health system, this only goes so far, because what you're going to have is someone senior, someone above you, breathing down your neck saying, what's the predefined end state? They want to know, if they're going to give you a bunch of money to do a project, what are you going to do for them at the end? Why should they take taxpayer dollars and give it to you for this initiative? The challenge is you're going to turn around and say, well, actually, I don't know what we're going to build because we're going to let patients define it. And at the end, I promise it's going to be super. It's just not what they want to hear. So there's this tension between doing really user-led initiatives, but also having a way to integrate that within the way health systems work. All too often what we do is we create like an innovation lab or a digital lab and we put it over the side in an organization. It's often not even in the same location. It's literally in a different place than the rest of the organization. And so while that's a great way to incubate ideas and to get people thinking in a different way outside the box, literally, you're not in the building, you're outside the box, joke. What it does is it silos that innovation. And when you try to bring them back together, you end up with a problem. Everything just kind of falls apart. And the reason it falls apart is not because the methods were wrong, because they're not. And it's not because the ideas were wrong, because often they're not. It's that we've tried to shoehorn innovation into a bureaucratic system without actually changing the way that old school system works. And at first glance, this doesn't really make sense. But if you go back to what I said about empowerment, this all holds true. Because empowerment is disruptive. Empowerment throws off existing hierarchies. It changes the power dynamics within things like health systems. So if we're authentically empowering patients to innovate different solutions, then we're having to give up some of our power in the organization. But usually we don't actually do that. Usually as an organization we say, we're really interested in empowering people, but we ourselves don't want to do much to change. Can't we just put them off in a digital lab and they'll solve the problem? So what we need to do is go back to users. The solution to this problem is to refocus on the user need. This is where you need to start if you want to change your organization to get more centered on innovation. There we go. Here's what you need to do. You need to bring decision makers together with the users. The most famous example used in government to illustrate this was when they made decision makers sit down in a room and watch service users try to negotiate a poorly designed, clunky service. In 30 minutes, suddenly people understood why it was so important to have diversity in our solutions, because they saw everyone they were excluding. It was a crash course in empathy for people who had no idea what they were talking about. It forced people to have a wake-up call, to realize that having a patient-led solution is not only critical to including everyone, it also is going to call for organizations to be more adaptable, to include those solutions, to change our way of working. So we're really close to getting this right. We definitely have the methodologies. You see this in industry, they're totally crushing it. We have tons of great ideas. So many people here today, so many of the things we've spoken about earlier in previous sessions have given us so many ideas that we can scale. The issue is literally just the doing it. And I kind of feel like it's mainly for people within the system to start stepping up to do that. So, to the patients, I encourage them to keep pushing the system to change and to adapt. But more importantly, for people like me working within health systems, I really challenge us to go within our organizations to have super awkward conversations that push our organizations to, rock the boat, change some things, be more inclusive of patient innovation. That's where we're going to get this done. Thanks very much.
While we are fixing our technical difficulties, thank you, Dave and Katherine. That was an excellent talk about the way in which innovation is going. If you guys have questions, feel free to ask, but I'm actually going to just kind of get the question started because I think she's touching on sort of the language of innovation. I think we've made in the last 5 years some pretty spectacular changes in the way we talk about healthcare innovation, but I think we're kind of on version 2 of that, right? Do you agree? So what do you think are some of the key vocabulary terms when you're talking to decision makers in hospitals that you think if someone wanted to make innovative changes in their hospital, what are some key terms that perhaps may give them, the decision makers may want to give more time to someone who is saying, hey, listen, there's a problem that I want to solve?
Thanks very much. That's a really great question, and I have what is arguably going to be a really boring answer, but I'll try to jazz it up. So I think, I spoke about language a lot at the beginning of the presentation, and it's a really almost boring, pedantic thing to talk about, to be hung up on what words mean. It seems totally too academic for practical use. But what I've noticed is that the reason I'm always defining things is it's not till way late in the game that we realize we're actually talking about two separate things. So if you think about any good academic article, oh good, we're back. The first thing they do when you read an academic article is they define the terms, and that sets the stage. That's the conditions of play. And we need to do the exact same thing in innovation. If we're going to talk about co-production, then define if you mean we spoke to 2 people one time for 10 minutes, or if you mean patients are there with us in the lab every single day, day in, day out, and we're paying them. It's quite a different thing. And I think that's how we went off track, is that people just thought, oh, well, I spoke to someone on the side of the road, so I engaged with users. And I'm not saying that guerrilla research is bad. There's a time and place for everything like that. But you just need to be clear about what you're doing, because if not, you can't differentiate who's totally bullshitting you and who's actually doing a good job. Another question, but I don't know if you want to wait.
Okay.